Good evening, everyone. You are welcome to this session of anatomy class, where we will discuss the anatomy of the peritoneum and the peritoneal cavity. So it is very important for any clinician to understand the anatomy of the peritoneum because of its relevance in clinical practice. Of course, we know the peritoneum is the largest cavity in the body, and of course, it contains important organs which are being lubricated by fluid that is secreted by the serous surface of this peritoneal lining. And of course, this fluid, when it exceeds a certain level, it indicates presence of pathology, as we know when it becomes much. There is ascites. And of course, this fluid is not more than 50 to 75 mils normally. And when you see the peritoneum containing fluid greater than this amount, up to 150 mils, you diagnose that as patient is having minimal ascites. And sometimes you cannot even pick this clinically until you do an ultrasound scan for mild ascites. And sometimes when it is moderate ascites, you pick that through a clinical demonstration called shifting dullness, which you pick moderate ascites. And when it is gross ascites, you can see that obviously, and you can pick that with fluid trial. Now, in certain cases where you can have peritonitis, which is inflammation of the peritoneum, and this will present with some classical clinical signs, which you demonstrate as a clinician and make a diagnosis of peritonitis, which could either be primary, secondary, or tertiary peritonitis. And in some other relevant clinical conditions where you have metastatic deposit of malignant tumors in the peritoneal lining, and that is called carcinomatosis peritonei. When you have tumor cells depositing on peritoneal surface, they elaborate vascular endothelial growth factors, and these will cause what is called neovascularization. And the neovascularization and hyperpermeability will cause exudation of fluid into this cavity, which will lead to peritonitis. There are several clinical significance of the peritoneum. But of course, you know, anatomy is the foundation of surgery, as well as the clinical practice. Without understanding the bedrock, you have difficulty in making correct diagnosis. So today, we are going to be talking about the peritoneum, the anatomy of the peritoneum. The peritoneum is a thin serous membrane that line the walls of the abdominal and pelvic cavities and cover the organs within these cavities. There are two parts of the peritoneum: the parietal peritoneum that lines the wall of the abdominal cavity and pelvic cavity, and the visceral peritoneum that covers the organ, as depicted on this picture. This yellow color is the cavity, and you have the abdominal wall that is lined by the parietal peritoneum that is depicted by the blue line. The inner wall is lined by parietal peritoneum that is depicted by the red line, while the visceral peritoneum that is lining the organ is depicted by this blue line. You can see it is lining the abdominal viscera. And of course, these organs are submerged in the cavity. They are submerged in the peritoneal cavity. In a true sense, per se, they are not truly in the cavity per se because they are covered. However, they are submerged, lined by the visceral peritoneum. Now, those structures that are submerged in this cavity are called intraperitoneal structures. Those structures that are behind this cavity are called retroperitoneal structures. So, as we mentioned, the cavity is the potential space between the parietal and the visceral layer of peritoneum. As we demonstrated earlier, this is the cavity, okay? And you have the visceral peritoneum lining the organs. You can see, while the parietal peritoneum is lining the wall, and in between you have the cavity. In the male, it is a closed sac, but in females, there is a communication with the exterior through the uterine tube, the uterus and the vagina. You should know that in females, the peritoneal cavity communicates with the exterior, and these serve as a risk factor in patients that develops primary peritonitis. Primary peritonitis usually is seen in patients with either ascites or in young females. In young females, because there is communication of the peritoneal cavity through the fallopian tubes, they could have ascending infection, which spreads from the genital tract into the peritoneal cavity through the fallopian tubes. And that is a form of primary peritonitis. Now, patients with ascites could also develop primary peritonitis from spontaneous bacterial infection, especially patients with chronic liver disease with ascites. They develop spontaneous bacterial peritonitis. So these two forms are regarded as primary peritonitis. There are other forms of peritonitis that are termed secondary peritonitis and tertiary peritonitis. You should know that the peritoneal cavity contains a thin layer of fluid that lubricates the peritoneal surfaces. The peritoneal cavity normally contains approximately 50 to 75 mL of fluid. I have a patient currently in the ward. We did laparotomy for in the post-operative period. He started developing swinging pyrexia. So we did an abdominal ultrasound scan for him, and it says there is a minimal collection. They quantified the fluid. It was about 20 mL of fluid. I told them that this amount is not significant, that may even warrant re-exploration or even cause this swinging pyrexia as an intra-abdominal abscess. We should look for other sources. But because there was no obvious source we saw, I requested for an abdominal CT scan, which will give us a better representation of the fluid quantity and the spaces of collection, because you know ultrasound scans tend to reflect the gases in the bowel, tend to reflect the echo sound, so you will not get a good picture. And after doing CT scan, we saw about 50 mL. The total amount of fluid that was estimated within the abdominal cavity was about 50 mL. I told them it is still within the normal amount of peritoneal collection. Okay, let us look for other sources. And lo and behold, when the central line was removed, there was egress of pus. So it was the central line that was infected. And after removal, we now saw that that was the focus of the sepsis of that patient. So anatomy, the knowledge of this will give you an eye there on insights of a patient's condition. So you should know this. The normal peritoneal cavity contains about 50 to 75 mL of fluid that keeps the organs well lubricated. What are the various functions of the peritoneum? It secretes a lubricating serous fluid that continuously moistens the associated organs. Fat storage, it stores a lot of fat. It has a defensive role by presence of lymphatic vessels and node, and it supports the abdominal viscera. As we mentioned earlier, those structures that are within this cavity are termed intraperitoneal organs. Those structures that are outside the cavity are termed retroperitoneal or extraperitoneal structures. The intraperitoneal organs, now when it is almost totally covered by visceral peritoneum, what are they? The stomach, jejunum, ileum, spleen are intraperitoneal organs. Retroperitoneal organs lie behind the peritoneum and are only partially covered with visceral peritoneum. The pancreas, the ascending and descending part of the colon are retroperitoneal. No organ, however, is actually within the peritoneal cavity, because if you have an organ, then it is covered by visceral peritoneum. Even though it is submerged within that cavity, but is actually not inside the cavity per se in the true sense, because it is lined by visceral peritoneum. But however, these organs are described as intraperitoneal structures. Now, how is the peritoneal cavity subdivided? The peritoneal cavity, as we mentioned, is the largest cavity in the body, and it is divided into two parts: the greater sac and the lesser sac. On this diagram, this pinkish portion is described as the greater sac, while this bluish portion is described as the lesser sac. If you notice, the greater sac is the main compartment and extends from the diaphragm down into the pelvis. It is the biggest or the bigger portion of the peritoneal cavity. The lesser sac is smaller and lies behind the stomach. Communication between them is by the epiploic foramen, or the foramen of Winslow. Now, if this is the peritoneal cavity, okay, and you have organs, roughly the liver, the stomach, okay, let's say transverse colon, small bowel, and so on. And there are sleeves of peritoneal lining covering these organs. You can see it has separated these organs into two portions. It has separated the cavity into two sacs. This larger one here is the greater sac. The one behind these organs now is the lesser sac. And there is communication between this greater and the lesser sac, which we shall see the details. And that is called the foramen of Winslow. Now, if you look at this diagram, you can see this is the foramen, the epiploic foramen. And you will see the clinical significance of dividing these into different compartments or cavities. Now, we've seen that the greater sac is the bigger compartment of the peritoneal cavity. The lesser sac is also called the omental bursa. Now you can see it is just behind the stomach, beneath the liver, okay, and it is between the stomach and the transverse colon. This is the transverse colon. Now, this bluish portion is described as the omental bursa or the lesser sac. Where is it situated, the position? It is situated behind the lesser omentum and the stomach. This sleeve of peritoneal fold is called the lesser omentum, that connects the liver to the stomach. That is the lesser omentum. So this is the stomach, and this is the greater omentum. It now folded to attach to the transverse colon, and this is called the transverse mesocolon. And of course, this is the retroperitoneal space here and the parietal peritoneum. So this is called the lesser sac. That is the position. What are the walls? Superiorly, it is bounded by the peritoneum, which covers the caudate lobe of the liver and diaphragm. You should be very careful with all these borders, because in your MCQ, you might just see quadrate lobe instead of caudate lobe. So you should remember this upper border is the caudate lobe. Then the other portion, you have the diaphragm, forming the superior border of the lesser omentum. Anteriorly, as we mentioned, is formed by the lesser omentum that connects the liver to the stomach. We shall see the anatomy of this in detail. Okay. The peritoneum of the posterior wall of the stomach, this, okay, forms the anterior border, and the anterior layer of the greater omentum. This is the anterior layer of the greater omentum, and this is its posterior layer. So, anterior border is formed by the lesser omentum, peritoneum of the posterior wall of the stomach, and anterior two layers, because these are double layers of the omentum. These layers are doubled. The inferior border, okay, area of anterior and posterior two layers of the greater omentum, okay, this. Then posteriorly is formed by the posterior two layers of greater omentum, that is this. I told you the omentum, these layers are double layer. It's a fold of double layer. That is the omentum, a fold of double layer. So we said posterior is formed by posterior two layers of greater omentum, transverse colon, transverse mesocolon. This is the transverse colon as we mentioned, transverse mesocolon. Okay. Now, there are some structures in the retroperitoneum that forms parts of the posterior border, and this include the pancreas, the kidney, and the suprarenal gland. Now, on the left side, of course, naturally, since it has all the borders, it will have a left side and a right side. On the left side, what forms the border? The spleen, the gastrosplenic ligament, and the splenorenal ligament. You should remind me when we are talking about this ligament, if I forgot to tell you the clinical significance of this ligament, of the spleen. Then on the right side, there is the omental foramen. The omental foramen. Okay. So these are the borders of the lesser sac. Now, still, if you look at this image, the stomach is being lifted up to show you those structures that forms parts of the posterior border, and at the same time, they form part of the stomach bed. You can see this stomach is lifted up. You can see there's the pancreas, this is the splenic artery, okay? And this cavity here behind the stomach is called the lesser sac. The omental bursa communicates with the greater sac through the omental foramen, also known as the epiploic foramen, an opening situated posterior to the free edge of the lesser omentum, forming the hepatoduodenal ligament. Okay, if you look at this diagram above this one, this opening, okay, is the epiploic foramen. It is called Foramen of Winslow. Now, just look at anterior to the Foramen of Winslow. You will notice there are three structures that are arranged in this manner. A portal vein posteriorly, that is this structure. I'm talking about these three structures. Common bile duct on the right and hepatic artery on the left. Now, this diagram I'm drawing, don't forget the position and their location is a common MCQ question. The arrangement of the portal triad, okay? You have the portal vein posteriorly. You have the bile duct on the right and the hepatic artery on the left. That arrangement. And these three structures are within the hepatoduodenal ligaments in the free end of the lesser omentum, which we will see shortly. Now, the reason why I'm showing you this, you should understand the clinical significance of this foramen of Winslow or epiploic foramen. When a patient sustains blunt abdominal with hepatic injury, laceration, during laparotomy, when you open the abdomen and you notice bleeding from the liver, how do you secure that hemostasis? Temporarily, you do what is called the Pringles maneuver. You do the Pringles maneuver. You insinuate your index finger into the foramen Winslow and the thumb above this. Then you apply pressure. When you apply pressure, you know the blood supply to the liver is via the portal vein and the hepatic artery, okay? When you do that, about 80% of the bleeding will stop, okay? You secure a temporal hemostasis by doing a Pringles maneuver. You insinuate your index finger into the foramen Winslow and the thumb above these three structures. You apply pressure and up to 80% of the bleeding will stop. Why not 100%? Because there is the hepatic vein that drains into the inferior vena cava. There is a retrograde flow. So the Pringles maneuver, in case of your MCQ, you should know it does not secure 100% hemostasis. You will understand this better when we are discussing the anatomy of the liver. So that is the epiploic foramen, or the foramen Winslow. Okay, and secondly, take note of the positioning. You might be confused and told that the portal vein is located to the right or to the left or bile duct posteriorly. Just remember your diagram, have the mental picture. You have portal vein posteriorly, hepatic artery to the left, and bile duct to the right. And they are at the free margin of this ligament here. Okay? And you have the epiploic foramen. Though we'll see the details of this. And in this lower image, you can see this green arrow indicating how you access the lesser sac or the omental bursa. Now, what are the boundaries of the omental foramen? You can see we are emphasizing on this because it has a lot of clinical significance. And of course, those setting your MCQs, the way I'm emphasizing on the significance of important anatomical structure, when they come to set your questions, they also pay attention to relevant anatomy in surgery. Now, what are the boundaries of the omental foramen? Anteriorly, if this is the foramen on this image, anteriorly, this is anterior, this is posterior. Anteriorly is the hepatoduodenal ligament, free edge of the lesser omentum. The free edge is called hepatoduodenal ligament, as the name implies, containing the portal vein, hepatic artery, and bile duct. Coincidentally, I was taking a bedside with residents this evening. We were discussing a patient with obstructive jaundice, and I asked them about the portal triad as well as their positioning. And of course, they were all guessing. So you should carry your knowledge of anatomy along to your practice. Posteriorly, the inferior vena cava. There was a time a surgeon I know was doing a procedure. And of course, the tumor was attached to this inferior vena cava. And in trying to mobilize this tumor, there was avulsion of this vessel. And of course, the entire abdominal cavity was filled with blood, and the patient arrested and died. So don't forget, when you put your index finger in the foramen Winslow and the thumb anteriorly, just know that behind that index finger is a great vessel there called the inferior vena cava, and it is taking blood into the heart. So don't think it's just like a toy you play with. Just know that there are vital structures there. Okay? Posteriorly, you can see this bluish structure is the IVC. I know you won't forget because I told you somebody avoids the vessel. You know, if you want to make people remember something, it's either you tell them this is money they will never forget, or you tell them something related to debt. They will pay attention. So inferior vena cava and right cross of the diaphragm covered with parietal peritoneum. You should know that they are retroperitoneal. Now, superiorly to the omental foramen is the liver, covered by visceral peritoneum, and inferiorly, superior or first part of the duodenum. Now, this is better demonstrated in this image. That is the inferior. This is the foramen here. This is the lesser omentum, and this free edge is the hepatoduodenal ligament. As you can see, the inferior border is the superior or first part of the duodenum, and you can see that blue arrow is leading into the lesser omentum. And this other image here is lifting up the stomach so that you have a mental picture of what that cavity looks like. Now, the peritoneal reflections or folds. We said there are two parts, the parietal and the visceral. The parietal is lining the wall, the visceral is covering the organs. You know, a peritoneal reflection that connects the intestine and the body wall is usually named according to the part of the gut which it's attached. For example, the reflection to jejunum and ileum is termed mesentery. When you say mesentery, of course, intestine, small intestine. That to the transverse colon is mesocolon. Okay? If this is the parietal peritoneum, this is the posterior abdominal wall, and these two layers split to cover the small bowel. If this is the small bowel, this attachment now, or fold or reflection, is termed mesentery. If you have parietal peritoneum encircling the colon, this is called the mesocolon. Some peritoneal reflections between organs or between the body wall and organs are termed ligaments or folds. Most of such ligaments or folds contain blood vessels. Broad peritoneal sheets associated with the stomach are termed omentum. We shall see that. Now, this is omentum. This is the stomach. And you can see the two layers of peritoneum coming over the stomach, forming an anterior double layer, and at the lower limits, they folded upward. So this fold is called greater omentum. Okay? They are called omentum. Now, the two-layered fold of peritoneum that extend from the stomach to adjacent organ. Now, there are two omentum. This is the lesser, the one coming from the liver, and this bigger one, as we mentioned, that have a double layer and folded up to attach to the transverse colon from the stomach, is the greater omentum. So that's why sometimes it is called gastrocolic ligament. Gastrocolic ligament, because this is the transverse colon. This is the transverse mesocolon. This is the mesentery, okay, of the small intestine. Now, let us see this lesser omentum and the structures within it clearly. And of course, without even mentioning too much, if you look at this image, you will see an abdominal aorta just lying here. So don't think you are a super surgeon. You will just pass a long scissors and start cutting as if you are cutting cadaver. Mark you can see the abdominal aorta just behind that, and a branch from the celiac plexus there, celiac trunk, sorry. Now, the lesser omentum is a two-layered fold of peritoneum which extends from porta hepatis. Now, this porta hepatis, okay, the parts of the liver through which structures enter and leave the liver is the porta hepatis. So you should know that the lesser omentum arises from the porta hepatis, okay, and it extends to the lesser curvature of the stomach and the superior or first part of the duodenum. Now, the hepatogastric ligaments extend from porta hepatis to lesser curvature. So this part is called hepatogastric, as the name implies. This other portion at the free edge that contain the structures which we already described is called hepatoduodenal ligament. Extends from porta hepatis to superior part of duodenum, contains common bile duct, proper hepatic artery, and hepatic portal vein. Now, this is the greater omentum. It's four-layer fold of peritoneum. The anterior two layers descend from greater curvature of the stomach, and superior parts of duodenum, and hangs down like an apron in front of coils of small intestine, and then turns upward to attach to the transverse colon. We've all described this. We're doing surgery with a resident. So she saw me after lavaging, putting all the intestine in place. I now drew this greater omentum down like an apron to cover the intestine down to the pelvis. She now asked, why did I do that? I covered the intestine with this greater omentum before closing the anterior abdominal wall. She asked, why did I do that? I told her, this structure prevents adhesions. when you allow your incision in contact with the intestine, they develop adhesions, and subsequently they will come up with post-operative adhesive intestinal obstruction. But if this omentum is placed in between that anterior abdominal wall and your intestine, they won't come up with that adhesion. So naturally, it falls down like an apron between the anterior abdominal wall and the intestine. Now, the greater omentum extends superiorly laterally to the left and inferiorly from the greater curvature of the stomach and the proximal part of the duodenum. It has three parts. The gastrophrenic ligament between the greater curvature of the stomach and the diaphragm. You might not understand the significance of this until when you start surgery. You want to do a gastrectomy because you know the stomach will be attached, of course, to the position it is by some certain ligaments. So you have to release all those ligaments. So you should have all this in mind. The gastrosplenic ligament, okay, between the greater curvature of the stomach and the spleen. So the gastrosplenic ligament is derived from the greater omentum. The gastrophrenic ligament is derived from the greater omentum. Then this gastrocolic ligament from the inferior portion of the greater curvature of the stomach, okay? The gastrocolic ligament is the largest part, descending anteriorly and inferiorly beyond the transverse colon, and then ascend again posteriorly, fusing with the visceral peritoneum of the transverse colon and superior layer of the mesentery. Now, what you should also know, it's of clinical significance, at the portion where this greater omentum attaches to the transverse colon, there is a bloodless spleen. When you are doing either gastrectomy or transverse colectomy, you are dissecting of this greater omentum at that bloodless spleen. Why? Because this is laden with blood vessels. If you just cut through, there will be a lot of bleeding and you have to be securing a lot of hemostasis. You understand? So you have to go to that bloodless spleen. Simply, you can just excise this from the transverse colon. And of course, another clinical significance you need to know, if it is a tumor, malignant tumor of the stomach, you take the stomach along with all this omentum. You do what is called omentectomy. You have to take the omentum because the omentum will be laden with a lot of malignant cells. So you have to excise that along with the stomach. What are the functions of the greater omentum? It has protective function. The greater omentum contains numerous fixed macrophages, which performs an important protective function. Storehouse for fats. The greater omentum is usually thin and presents a cribriform appearance, but always contains some adipose tissue, which in fatty people, okay, is present in considerable quantity. Now, is the policeman of the abdomen. Migration and limitation of the spread of infection. The greater omentum may limit spread of infection in the peritoneal cavity because it will migrate to sites of any inflammation in the peritoneal cavity and wrap itself around such a site. The greater omentum is commonly referred to as policeman of the peritoneal cavity, policeman of the abdomen. Sometimes when you are doing laparotomy, you realize that the lower portion, if for example, a patient has ruptured appendix, you realize that the pulse and everything is limited to the right iliac fossa because the omentum has limited the spread of that infection. At the upper portion, it will remain very clean. Now, in such situation, you won't say, okay, because you have a lot of water, you now start lavaging and spreading the infection everywhere. You can do a controlled lavage, okay? Now, we've talked about the mesentery. It is very important you understand its position, its length, its significance. There was a patient I managed with enteroatmospheric fistula. This patient had multiple surgeries in a peripheral hospital. They were just excising portions of her small intestine and reanastomosing. And the anastomosis kept on failing. Instead of exteriorizing for inflammation and contamination to subside, they kept on anastomosing until they took out almost 250 centimeters of her small bowel, to an extent that she doesn't even have significant portion of the mesentery. So any anastomosis they do, it will be under tension. It will break down. And lo and behold, when the patient was referred to me, I saw an enteroatmospheric fistula. And when I opened to exteriorize the bowel, and of course I saw she doesn't have mesentery that can even allow you do an ileostomy. She had only 90 centimeters of the small intestine, okay? Majority of the portion was even the jejunum that doesn't absorb, so she was just pouring a lot of fluid. And of course, that is a different story and a challenging one, which we are not talking about here. In essence, you should know that the mobility of this small bowel and your ability to anastomose successfully depends on the presence of the sufficient mesentery. And this mesentery, okay, that attach this small intestine to the posterior abdominal wall or other bowel, carries within it the blood supply to this small bowel, as well as its nervous, as well as its innervation. The mesentery is two-layered fold of peritoneum that attach the intestine to the posterior abdominal wall, okay? And as we said, for that of the large bowel, strictly speaking, is called mesocolon, and that of the small bowel is called mesentery. Now, the mesentery of the small bowel, you should know that it suspends the small intestine from the posterior abdominal wall, and it is broad and fan-shaped. It is fan shape. You can see at the root, it is limited than at the outer margin. So it is fan shape. The root of the mesentery is 15 centimeters long, and it is directed obliquely from the left of the L2 vertebra to the right. So it's an oblique orientation, and this is just 15 cm. You wonder why the small bowel is coiled, has a lot of coil, if 15 cm is carrying up to 500 centimeters, for example. You could imagine how there will be a lot of coil for this to fit into a 15 centimeter of root. Okay? So it is from L2 to the right sacroiliac joint. On the left and on the right here is at the sacroiliac joint. Don't forget this. Don't forget the length of the root of the mesentery. Contents: the jejunal and ileal branches of the superior mesenteric artery. What are the branches of the superior mesenteric artery? Superior pancreaticoduodenal artery, intestinal arteries, which are jejunal and ileal arteries. Okay, you have the right colic artery, ileocolic artery. So among the superior mesenteric arteries, you have intestinal arteries, which are the jejunal and the ileal. They run through the mesentery. Don't forget, the superior mesenteric artery supplies the midgut. The midgut extends from the ampulla of Vata in the second part of the duodenum up to the proximal two-thirds of the transverse colon. All these are distributions of the superior mesenteric artery, and the branches are superior pancreaticoduodenal artery, intestinal arteries, which are jejunal and ileal arteries, right colic artery, ileocolic artery, middle colic artery. So it contains the superior mesenteric arteries and veins, nerve plexus, lymphatic vessels, and connective tissue fat. So that is about the mesentery of the small intestine. The Mesoappendix is a triangular mesentery, extends from the terminal part of the ileum to the appendix. When you are doing appendectomy, you have to create a window in the Mesoappendix. If this is the appendix, this is the cecum. Okay, you have the terminal ileum. Now the appendicular artery is here. So you create a window, you put your clamp this artery, you suture ligate and excise before you now tackle the appendix. You can't just go and start removing appendix when the blood supply is intact. The blood supply is carried in the Mesoappendix. The appendicular artery runs in the 3 margin of the mesoappendix. As you can see, during appendectomy, you have to ligate that artery. Failure to ligate this artery properly or slippage of suture from the mesoappendix will give you a primary hemorrhage during appendectomy. Sometimes you might be surprised, is it not just appendectomy? The bleeding from this mesoappendix can be torrential and you get confused. In fact, it might even lead you to create a serious complication. You might even end up devascularizing the terminal ileum, and patients will come up with serious complications that might even require ileostomy later. So don't just say, is it not just appendectomy? No. Now, you should know the mesoappendix is a triangular mesentery that carries the appendicular artery at its 3 margin. And this appendicular artery is ligated before doing appendicectomy or appendectomy, as you may want to call it. The transverse mesocolon is a double fold of peritoneum which connects the transverse colon to the posterior abdominal wall. The sigmoid mesocolon now, you know, the sigmoid colon is about 50 centimeters in length. It has a long mesentery, okay? And you can see it's an inverted V-shaped with the apex located, okay, in front of the ureter and the division of the common iliac artery. Okay, now let's quickly talk about the ligaments of the peritoneum. Now, ligaments of the peritoneum, 2-layered folds of peritoneum that attached the lesser mobile solid viscera to the abdominal wall. They attach solid organs to the abdominal wall, maintaining their position and stability. Let us look at the ligaments of the liver. Now, if you just take a glimpse of this picture, you will see this is the diaphragm. And just beneath the diaphragm, there is a ligament that is attaching the liver to this diaphragm, and this is called coronary ligament. Okay? Now, at the outer margin of this coronary ligament, you have triangular ligaments. The left triangular ligament and the right triangular ligament. Now, in front of the liver, there is a ligament that originates from the coronary ligament and comes down to form a double layer. And these ligaments attach the liver to the anterior abdominal wall. This ligament is called the falciform ligament. These ligaments keep the liver in its position. The falciform ligament divides the liver into the anatomic left lobe and the anatomic right lobe. You shall see subsequently, these are false lobes. All this right lobe you've been calling This as the left lobe of the liver and the right lobe of the liver. They are anatomic lobes, but the true physiologic lobe is here. This is where the true or the physiologic left and right lobe. And this line is called Cantley's line. We'll discuss that when talking about the anatomy of the liver. Here is the fossa of the gallbladder, the porta hepatis, and the inferior vena cava. So it is lined by the Cantley's line. Okay? So, but you should know, we are not talking about that now. We are talking about the falciform ligament that divides this into anatomic right and the left and the right lobe. Now, at the free end of this falciform ligament, a round ligament, the ligamentum teres of the liver, which is an obliterated umbilical vein, forming free border of falciform ligaments. Okay, now let's continue. At least you have this at your mental picture before we take the ligaments in detail. Now, I usually give people an assignment. Residents, I'll give you this assignment now, and I'm not going to tell you the answer. I'll allow you to figure it out yourself. But if anybody can figure it out himself, maybe at the end of the class, you tell me the answer. When we are making incision for laparotomy, this is the abdomen, this is the umbilicus. If you remember when we discussed the anatomy of the anterior abdominal wall, we talked about various types of incision. We talked about the long midline incision. You skirt it around the umbilicus, okay, to the left side of the umbilicus, not to the right side. And I asked our residents, why do we normally skirt our incision to the left side of the umbilicus and not to the right side? If you figure that out, you will tell me. And if you don't tell me the answer correctly, I will not tell you. Go and find out. So, the various ligaments of the liver. Liver ligaments are double-layered folds of peritoneum that attach the liver to surrounding organs under the abdominal wall. The majority of the ligaments associated with the liver are remnants of embryological blood vessels that regressed as the fetus developed. The falciform ligament of the liver, we've talked about it. The ligamentum teres hepatis, coronary ligament, right triangular ligament. I know you are picturing all these things because you've seen that image. The left triangular ligament, hepatogastric ligament, we've talked about it. Hepatoduodenal ligament that contain those three structures we mentioned. I know there is nothing new to you, but however, there are some certain points you don't know about this ligament, which we'll discuss shortly. Falciform ligaments of the liver consists of double peritoneal layer, extends from the anterior abdominal wall to the liver. Coronary ligament. Parts of the peritoneal reflection that holds the liver to the inferior surface of the diaphragm. Now you should know it has two layers. One on the anterior part or the upper part of the diaphragm, and a more posterior part. And in between these two layers, there is no peritoneal covering. The area between the upper and lower part of the coronary ligament is the bare area of the liver. This area is devoid of peritoneum and lies in contact with the diaphragm. Now, I would give you an assignment. You tell me what are the unique features of the bare area of the liver in terms of, okay, the lymphatic drainage. Let me just allow you to find out what are the unique features of the bare area of the liver. So you can see the coronary ligaments. There's an upper portion that attach to the anterior layer that attach to the upper part of the diaphragm, and the posterior layer that is not even seen here. Okay, in between you have this portion that is called the bare area of the liver. Now on the right and the left triangular ligament, as you can see, this is the left triangular ligament and the right triangular ligament is here. We are going to see in a better image. They are formed by the right extremity of the coronary ligament and the left leaf of the falciform ligament. Okay. Okay. As the left triangular ligament is longer, take note of this. This is the left triangular ligament, this greenish portion is longer. This is the right triangular ligament. You can see it's shorter. Okay. Now, as the left triangular ligament is longer and travels along the liver for a greater distance, it becomes continuous with both the falciform ligament and the lesser omentum along its course. You can see anteriorly it continues with the falciform ligaments here, and posteriorly you can see it continues with what? The lesser omentum that attaches to the stomach that is here. Okay, so you should have this in mind when you see a question that says triangular ligament continues with the lesser omentum. You just be imagining how. Okay, the arrangement is such that the posterior layer of the left triangular ligament is continuous with the lesser omentum inferiorly. In turn, the anterior layer of the left triangular ligament is continuous with the falciform ligament superior medially. Now, that is about this left triangular ligament. Now on the right, you can see the right here. Right triangular ligament is relatively short structure. It begins at the apex of the bare area of the liver. This is the apex of the bare area of the liver, and is formed by the right part of both layers of the coronary ligament, this anterior and posterior layer of the coronary ligaments. And you should know for the left is by the falciform ligament and the coronary ligaments. Now, ligaments of the spleen. The gastrosplenic ligaments. If you remember, we said it arises from the greater omentum. It connects the fundus of the stomach to the hilum of the spleen. You can see this is the stomach and it connects to the spleen. If you are doing splenectomy, okay, you know that if you are doing splenectomy for elective, you have to ligate this and excise this ligament before excising the vessels, before ligation and excising the vessels. But if it is for trauma, you have to ligate the vessels first. In fact, most of these ligaments are already torn. The content is short gastric and left gastroepiploic vessels. Then the splenorenal ligament, you can see it. The splenorenal ligament extends between the hilum, this is the hilum of the spleen, and the anterior aspect of the kidney, the left kidney. The splenic vessels lie within the ligament as well as the tail of the pancreas. So the tail of the pancreas is at the hilum also. Now, don't forget, there is the gastrosplenic ligament containing short gastric vessels and left gastroepiploic vessel, the splenorenal ligament, and the phrenicosplenic ligament that is attaching it upward to the diaphragm, and the splenocholic ligament attaching it to the transverse colon. Okay, so you have 4 ligaments. What are the significance? I told you that I'll tell you the significance of this ligament. Now, you should know that it is the gastrosplenic ligaments that usually contain blood vessels, short gastric vessels. When you are ligating these vessels, you ligate it away from the fundus of the stomach. If not, they will have fundal ischemia, necrosis, perforation. It should be ligated closer to the spleen, away from the fundus of the stomach. Other ligaments are usually avascular, but what is the clinical significance? The clinical significance is patients with portal hypertension. These ligaments becomes vascularized. If you just go and excise them, thinking that, okay, they are anatomically, we know that they are avascular ligament, the patient will bleed torrentially. So in patients with portal hypertension, these ligaments all become vascularized. So you have to ligate and size. Ligaments of the stomach, talked about them. Hepatogastric ligament, gastrosplenic ligament, gastrophrenic ligament, gastrocholic, and gastropancreatic ligament. Now, there is what is termed the ligament of Trixie, or the ligament of Trix, or suspensory ligament of the duodenum. Okay, it is at the duodenojejunal junction. It's at the duodenojejunal junction. The ligament of Trachea attaches the DJ junction to the posterior abdominal wall, and that is the demarcation for upper and lower GI bleeding. Bleeding above the ligaments of Trachea is termed upper GI bleeding. Bleeding below the ligaments of Trachea is termed lower GI bleeding. This junction is called duodenojejunal junction. I'll give you an assignment. What important structure is just lateral to the DJ junction at the ligament of Trachea? What important, very important structure is just lateral to the ligament of Trachea? Go and check. The phrenicocholic ligament is a fold of peritoneum which is continued from the left colonic flexure to the diaphragm, opposite the 10th and 12th ribs. Opposite the 10th and 12th ribs. Now, let's talk about the folds and fossa of the anterior abdominal wall. I'll tell you a story about a patient from the clinical significance of this anatomy. I know, Dr. Abdullahi, you are sleeping. He won't eat until it's almost time for lecture. So, Dr. Abdullahi, you better wake up. Now, fossa, we'll talk about these folds. There's the median umbilical fold, medial umbilical folds. Don't confuse the two. Median umbilical fold, medial umbilical fold, lateral umbilical folds, supravesical fossa, medial inguinal fossa, and lateral inguinal fossa. Now let's talk about one after the other. But before I even talk about them, look at it so that you have a mental picture. Now, these are the midline. Is the median umbilical fold. I had a patient that I just reviewed her CT scan today, just today, few hours before these lectures. This lady came to me at my clinic some few weeks ago, about 3 weeks ago. She came with a history of recurrent umbilical pain, frequency of micturition, and dysuria. I asked her, and she told me that the history dated back to 10 years ago, when she was 16 years old. And at the same time, she has left-sided inguinal hernia. So anybody that sees her will confuse that recurrent abdominal pain, periumbilical pain, with the left inguinal hernia she has. When I examined her, the hernia was not complicated. In fact, it rarely comes out except when she does a strenuous activity. But of course, when you examine her clinically, she has periumbilical tenderness and she has history of frequency and dysuria. And there is what is called urachus. It's an embryonic structure that connects the umbilical cord to the bladder. And if you look at this, median umbilical fold, you can see it's coming from the umbilicus to the upper portion of the bladder. So I know your mind is already going to what I'm thinking. So I now thought of something, maybe a persistent urachus, and it's leading to infection into the bladder, because that persistent urachus could be either a persistent brachial sinus, it could be a patent urachal cyst, or it could be a bladder diverticulum, depending on what parts of this urachus obliterates, whether it's the proximal portion, distal portion, or proximal and distal portion. If the proximal portion up to this mid portion obliterates, it will form a bladder diverticulum. If the proximal and the distal portion obliterates, it will form a urachal cyst. If the distal portion obliterates, it will form a sinus onto the umbilicus. So I asked her to do an abdominal CT scan, and lo and behold, this patient has a urachal cyst that is infected. I now told her she has two independent pathology. And of course, we finish evaluating her. This coming next week, she will have excision of the urachal cyst because it has been there for 10 years and she has tendency for malignant transformation. So you can see this median umbilical fold. We've already known what it's all about. It contains median umbilical ligaments, which is an obliterated urachus that connects the bladder to the umbilicus. Okay, now you can see there's a lateral, there's a medial umbilical fold, this one now. Okay, containing obliterated umbilical artery. You have the lateral umbilical fold, okay, that is containing the inferior epigastric vessel. Now, on this side, you see the structures, and on this side, you see their content. The medial umbilical fold contains obliterated urachus. The medial umbilical fold contains obliterated umbilical artery, and the lateral umbilical folds contains the inferior epigastric vessels. Okay. Now let's quickly wrap up the lecture. We've taken too much time. Let me give you a chance to ask questions. Folds and recesses of the posterior abdominal wall. There is a superior duodenal fold and recess. Okay, they're on the posterior abdominal wall because you know the duodenum is a retroperitoneal structure, so it will have a fossa there. It will have a fold and a recess there. Inferior duodenal fold and recess. Okay, the intersigmoid recess formed by the inverted V. You can see it here. Attachment of the sigmoid mesocolon. Retrocecal recess, because the cecum is here, it will have a recess. And when you have the retrocolic appendix, retrocecal appendix, most of them, 75%, lie in that retrocecal recess. The hepatorenal recess lies between the right lobe of the liver, right kidney, right colic flexure, and it lowers parts of the peritoneal cavity when the subject is supine. The pouches of the peritoneum in males, you have the rectovesical pouch. In males, you can see this is a potential space for collection in peritonitis or pelvic abscess or intraperitoneal abscess. Now, it lies between the rectum and the urinary bladder, or the seminal vesicles and the ampullae ductus deferens. The rectovesical pouch is the lowest part of the peritoneal cavity in anatomical position in males. In females, there is the rectouretrine pouch between the rectum and the uterus, and this is called the pouch of Douglas. Okay. Then the vesicle uterine pouch between the bladder and the uterus. Now, this is also very important. This anatomy is very important. You should know there's this division you need to understand about the peritoneum and what landmarks divide this peritoneal cavity. The transverse mesocolon, if you remember, the mesentery of the transverse colon, it divides the abdominal cavity into the supracolic compartments containing the stomach, liver, spleen. Don't forget, the transverse mesocolon, if you have the peritoneal cavity, okay, you have the transverse colon here. This is the transverse mesocolon. It divides the peritoneal cavity into supracolic compartment and infracolic compartment containing the small intestine, ascending and descending colon. So these contain liver, spleen, stomach, while this contains small intestine, ascending colon, and descending colon. Now, the supracholic compartment has the subsphenic, it has two spaces. There is because this is the diaphragm, okay? There's the subphrenic space, then you have the liver, then you now have the subhepatic space. This you see the clinical significance. The subphrenic abscess can collect now. There's what is called Barnard's aphorism. It says pause somewhere in a patient that is having swinging pyrexia and you did not see evidence of abscess. The Barnard's aphorism says there's pause somewhere, pause nowhere, pause under the diaphragm. You should go and check under the diaphragm. There's pause somewhere, you check, there's pause nowhere, then there's pause under the diaphragm. You can be having swinging pyrexia. Now the subhepatic space beneath the liver, now if this is the liver, now it has the right portion and the left portion. The subhepatic space is divided into two now. This is the subphrenic. This is the subhepatic that is further divided into the right part and the left part. Now, listen carefully. Listen carefully. The right subhepatic space. The right subhepatic space is also called the Morrison's pouch. I told you it has two compartments, supracholic and infracholic, divided by the transverse mesocolon. The supracholic has two portions, the subphrenic and the subhepatic. The subphrenic, I told you its clinical significance, Barnard's aphorism. Pus can accumulate there. Secondly, air under the diaphragm signifies perforation of viscous. The subhepatic space has the right part and the left part. The right part, the right subhepatic space is also called the Morrison's pouch, while the left subhepatic space is the lesser sac. Now let's go back to that image. If you look at the infracholic compartment, you have paracholic gutters. These are called paracholic gutters. All these spaces are potential spaces for collection. The subphrenic, the Morrison's pouch, the lesser sac, the paracholic gutter. All these are potential space for abscess collection. Intrapelvic abscess are collected in these spaces, as well as interloop abscess between small intestine. What is the connection between the supra and the infracolic compartment. What is the connection? Okay, we said the subphrenic is divided by the attachment of the falciform ligament into the right and left subphrenic space. The subhepatic is divided into the right subhepatic, which is the Morrison's pouch, and the left subhepatic, which is the lesser sac. Now, the infracolic compartment is divided into the right and the left infracolic space by the mesentery of the small bowel. The free communication occurs between the supra and the infracolic compartment through the paracolic gutters. You can see there is where free communication occurs between supra and infracolic compartment via the paracolic gutters. And of course, we said the infracolic compartment is divided into right and left by the infracolic space. By the what? Sorry, by the mesentery. Remember this mesentery that we say is 15 cm from L2 to sacroiliac spine, if you have not forgotten. So this is the summary of all and ligaments and their function. Okay, you have the slides, we've discussed them, and you can go through them. So we have come to the end of the lecture for today. Now it's time to entertain questions. If you have any question, you can mute yourself and ask. Thank you very much for participating. So any question? If you have any,
there are some few questions, and then I think when you were describing the bloodless plane of the greater omentum, I was a bit distracted. I missed that portion, that part. That's number one.
Okay.
Then second one is that I also miss one of the ligaments you mentioned, the peritoneum. The first one you mentioned the ligament of the liver, ligaments of the liver. The second one was the ligaments of the spleen. And then I think I was lost the third one. I got the fourth one, ligament of thread Z. So I don't know. I missed the third one.
Okay. So you missed them.
The third one.
Okay.
I did not document it. I was joking. I could not get it.
Are you sure you are not sleeping along with Dr. Abdullah?
I said when you mentioned sleeping, I believe I was supposed to sleep, but God spoke. I did not actually. And then I don't know. I wanted to attempt that assignment you gave us of the incision.
Okay, you can.
Yes. Okay, can I guess?
Oh, I thought you know, so you are guessing.
Okay, no. I think I know, sir. You know, when you are in the presence of the king, you don't boast of of power. Yes, sir. I think one of the reasons why the midline incision is taken to the left is that the falciform ligament of the liver is slightly to the right. And then we do not cross to the right also because the round ligament of the liver that contains the obliterated umbilical vein, umbilical artery rather. Occasionally, it may persist. It might persist. I mean, the disease to be obliterated, so such that when it is caught, there will be bleeding from the round ligament of the liver.
Okay, so you are not guessing. Why you have allowed all of them to fail the option.
Oh,
Then you will now answer. I know most of them. Now they will claim that they all know the answer. Dr. Abdullah, are you awake?
Thank you, sir.
Are we together?
Yes, sir. We are, we are together.
Okay. Or I just woke you up.
Just a little.
Your network, you are in your village. Okay, any other questions?
Yes, that's very.
For this, your ligament you are mentioning, since you missed them, maybe you were sleeping, the lecture is recorded. You go and watch it again. Because,
Okay, sir.
yes,
Okay, sir.
you go and watch it so that we don't repeat the lecture again. Yes, any
Okay,
other
sir.
question? Okay, you see, everybody is sleeping. Any other question? Where is Dr. Bello? Dr. Bello is not with us today. Where is Dr. Aisha? Where is Ayush? She's not with us today. They are the regular candidate that asks questions. So in the absence of any question, we are going to stop here. We'll resume our assignments on Monday, inshallah. So thank you very much, everyone, for participating.
Thank you, sir.
Thank you, sir.
Yeah.